Dear audience, dear chairs, good morning, and thank you to let me introduce my PhD thesis about the novel treatment of advanced urothelial cancer. I'm Mohammed Altenni, and I'm working at the Peterfield Hospital. I'm a second-year PhD student, and my mission to provide outstanding clinical treatment for patients with urothelial cancer in a strong academic environment. I have a vision to serve bladder cancer patients with compassion, professionalism, integrity, and excellence. According to this, I have two ongoing specific goals, both of them about the same disease, which are advanced urothelial cancer with a different kind of novel treatment. The first topic, which is identifying patients who would benefit from enfortumab vedotin in advanced urothelial cancer. A little bit about the background here, that as we know that urothelial cancer, 5-year survival, metastatic urothelial cancer, 5-year survival is very poor, it's around 5%. And those patients with advanced disease are undertreated, especially in the third-line setting. Less than 10% of them will receive the therapy. And enfortumab vedotin is a new third-line therapy from 2022, according to the EV301 randomized trial, and recently in 2023, December, approved for the first-line therapy with pembrolizumab. As we can see here, that enfortumab vedotin have a superiority in overall survival and objective response rate than chemotherapy. The problem here that in the real world, those patients are less selected than in randomized control trials, and our aim here to identify in our clinical practice which patient will benefit more from the novel treatment. Our clinical question, how do different clinical parameters impact the outcomes of enfortumab vedotin treated advanced urothelial cancer? We used a PECO framework and our population patient with advanced urothelial cancer treated with EV. And we are comparing different patient characteristics and our outcomes, overall survival, progression-free survival, and radiographic response. We hypothesize that enfortumab vedotin provides greater benefit to advanced urothelial cancer patients with specific characteristics. We conducted our search key in three main databases, and we used the search key you can see below. We got more than 1,600 articles, and after the selection procedure, we ended up with 23 articles. Here is some of our results. In the first figure, I would like to interpret the included studies, and we divided it to the clinical and prospective studies and retrospective studies, and we measured the proportion of objective response rate between the two studies. As we can see in the lower part of the figure, that the difference between prospective and retrospective studies is 0.48. That means 48% higher objective response rate found in retrospective studies. And this result is statistically significant, and it might be relevant. In the second figure, we are comparing the odds ratio of objective response rate between patients who previously responded to immune checkpoint inhibitors with patients who not responded. And we have six articles here. As we can see, the odds ratio is 1.51. That means patients who previously responded to immune checkpoint inhibitors have a higher, 50% higher response rate to enfortumab vedotin. This result is statistically significant and clinically relevant. In the figure 3, we are comparing the ECOG status between ECOG 0 and 1 and a patient with the higher ECOG status, more than 1. And our results here is, show that patients with favorable ECOG status have a higher response rate and overall survival and progression-free survival. In the fourth figure, we are comparing the histology subtypes according to the objective response rate, also overall survival, progression-free survival, and we found that patients with pure urothelial cancer have a higher patient with urothelial cancer with variant histology have a lower progression-free survival. And for the objective response rate and overall survival, we didn't find significant result. Here is the summary of our investigated parameters in different characteristics. Is some laboratories characteristics and molecular So the limitation, the strength of our articles, this is the first systematic review and meta-analysis in this novel treatment with a large sample size, and we have some limitation also that we use just univariable analysis and the patient level data unavailable for all studies. And we have a limited studies investigated the molecular outcomes. We have a conclusion that enfortumab vedotin is effective treatment for advanced urothelial cancer patient, also in less selected real-world settings. And our implication for practice that enfortumab vedotin is effective not only in bladder cancer, also in upper urinary tract tumors. And enfortumab vedotin is more effective in chemo and immune checkpoint inhibitor responders. We found that FGFR mutation status does not associated with enfortumab vedotin sensitivity, and our implication for research that mechanistic research should reveal how the identified molecular factors influence enfortumab vedotin sensitivity. This is our manuscript status. We submitted our articles to the European Urology in December 2023, and we got a transfer a chance to European Urology Open Science. My second project is about the prognostic and predictive value of tumor mutation burden in immune checkpoint inhibitors treated urothelial cancer patients. As we know that urothelial cancer, we have around 500,000 new cases per year, and nearly half of them will die worldwide. And as immune checkpoint inhibitors are novel standard treatment for those patients, but the problem here that 25% of patients will benefit from this therapy, and while 75% will not benefit. Our aim here to enhance the understanding of tumor mutation burden as a predictive biomarker and to refine personalized treatment strategy in urothelial cancer therapy. Our clinical question: how tumor mutation burden impact the outcomes of immune checkpoint inhibitors treated advanced urothelial cancer patient. We used same PECO framework with our population, the patient with advanced urothelial cancer, and we are comparing a high TMB with the low TMB levels, and our outcomes, the same outcomes as a first project. We hypothesize that immune checkpoint inhibitors provide greater benefit to TMB positive advanced urothelial cancer patient, with a clinical research implication that TMB helps select patients for effective immune checkpoint inhibitor treatments and avoiding ineffective options. We conducted our search key in 3 main databases. By the search key you can see below, and we started the selection procedure, and now we are working in title and abstract selection. So this is our plan for the next 2 weeks. We would like to suggest a transfer submission, and for the second project, finish the selection. To sum up, I have 2 ongoing projects. First one submitted in December 2024, and the second one we would like to submit in May 2025. And I would like to thank you for your attention by my favorite quote, that be brave to stand for what you believe in, even if you stand alone. Thank you very much.
Thank you for the great presentation. Congratulations. I would like to ask about your second topic, which cutoff level you use in tumor mutation burden.
Thank you for your question. Yes, in the last few years, the agreement was 10 somatic mutation per megabase. So higher than 10 mutation per megabase is a high TMB. It's called high TMB.
Thank you.
I would have a question to the first project. You mentioned as a limitation it was an univariate model. Could you mention some relevant confounders in the topic?
Which type of confounders, if you ask?
For next project, for next research, which you would take into consideration, for example?
We would like, yes, as in the first project, when we started the project, it was very new therapy. So very little articles we had to be investigated. With all of articles have only univariable analysis. So that was not our problem with the topic. But for the second project, as immune checkpoint inhibitors therapy started in around 2016, so I think we will have a lot of articles, and we would like to also include some of multivariable analysis when we're investigating that tumor mutation burden. We would like to include a PDL1 and PD1 as also as a predictive biomarkers. If I understand. Thank you for your question.
Congratulations. I have just one question, because I'm a kidney transplant surgeon. And what's your opinion? For example, this cancer can be developed and transplanted kidney, or just in the original kidney? This carcinoma.
Thank you for your question. I would like to. So you mean that this cancer can be transmitted to the kidney which you implanted or transplanted? Yeah, that's your. Yeah, of course. As we know that urothelial cancer can be in the bladder and in the upper part. More higher, as we can say, recidiva found in after the upper urothelial cancer in the bladder, but in the opposite.
And the treatment is similarly than this case, or for example in kidney transplant patients' case, because the kidney transplant patients taking immunosuppressive drugs. And it's contraindication, for example, this medication or not? I just questioned. I don't know.
Yeah, it's really very hard to answer. But the problem here that if we are speaking about advanced urothelial cancer, it's a different kind. And if we are speaking about the urothelial cancer, it could be PT1, PTA. And so this is the difference. And a lot of treatment we have, but I don't think those patients will take this therapy because it's a kind of chemotherapy, so it's difficult to.
I would ask that what is the most expected side effect of enfortumab vedotin? How do you know?
The most expected side effects are, we can say, fatigue, itches, and some of patients have a hyperglycemia. Yeah, and some diarrhea is the same as of any kinds of chemotherapy. But I would like to mention that it's not really a chemo treatment. So it's an antibody drug conjugate and binding to the Nectin-4 and causing cells death by this line. But the size of effects is not as high as chemotherapy.
Thank you.
So the patient will benefit really from this treatment.
Is this drug for the first project that you said that only a smaller amount of the patients are getting it who could or who should. And I wanted to ask you that is this drug available in Hungary? Do you use it in your hospital, or do you have any experience with it? And whether about the cost, that is it? What is the cost of treatment?
We are trying to use it. So as of my knowledge, just 2 patients got the treatment and self-paid treatment. But we hope. I know that the oncologists are trying to give the treatment for the patient because it's really effective treatment.